This meeting is being recorded.
Good afternoon, everyone. Thank you for joining for the special NDLS session today. Today's topic is introduction of DTG 10 mg dispersible and scored tablets for CLHIV weighing less than 20 kg. And the speakers are Dr. Chinmay Das from NACO, Dr. Reshu Agarwal from CDC India, and Dr. Rohini Gupta from CLHIV. We welcome you all for today's session, requesting all the participants to please put their questions in the chat box. All the questions will be taken at the end of the session. I now request Chinmay ma'am for the opening remarks.
Thank you, Shweta. So very good afternoon, everyone. This is a special session of National Distance Learning Seminar Series. The reason why we are doing this special session is, as you all, some of you must be aware, some of you would be knowing details today about the introduction of pediatric DTG 10 milligram formulation for dispensation for the children living with HIV. So the importance of this formulation is that we have already introduced dolutegravir 50 mg earlier for adolescents and adults. So that was for those who had body weight more than 20 kg. But for children with the body weight less than 20 kg, we were using LPVR 4010 and also 125 in some cases. But now going ahead, we want to introduce the dolutegravir based regimen for these children. It being more safe, it being more potent, with lesser side effects, better tolerable, and less genetic barrier and less drug resistance. So we want to introduce this drug so that the treatment of the children, smaller children, will be more effective. So in the session that we have today, so my co-speakers, Dr. Reshu and Dr. Rohini, they'll take us through the technical aspects of the induction of this formulation and also the operational aspects. So at the end, I'll also request Dr. Purnima from my team to talk about a few aspects related to the monitoring part. So in the session today, what you will learn is whom should you give this formulation, how should you give, and when should you give. So be very mindful about knowing all these, because the prescription, the dispensation, the counseling aspects, counseling of caregivers mostly, please pay attention to this. And we hope that you also learn about how to report, how to record, how to monitor these patients who are going to be on this formulation of dolutegravir 10 milligram. And of course, through SOCH also, we have already have provisions of where to enter and how to look at it. So be very mindful. I hope we all have a good session and we all learn from the discussions that happen in the next 1 hour. If there are questions, obviously you'll be asking through chat box or you can unmute. However, still, if you feel you want a little more detailed discussion, then you can always write to NACO CST team. So best wishes and thank you. I hand over to Dr. Rohini or Shweta. Maybe you can take forward.
Yes, ma'am.
Thank you.
Rohini ma'am, you are requested to please continue.
Thank you, Dr. Chinmay, and thank you, Dr. Shweta. Welcome everyone. We will be talking about, discuss and understand what are the national guidelines on using dolutegravir 10 milligram based ART regimen in children less than 20 kgs. What is the first line ART regimen in ART naive children? What is the dosing of DTG 10 milligram in TB HIV co-infected children? What are the transitions? We need to transition all our children less than 20 kgs to DTG based, pediatric DTG based ART regimens. The next, what we'll be covering is counseling of children and caregivers for using DTG 10 milligram and monitoring children who have been started or transitioned to pediatric DTG 10 milligram based ART regimens. So let's go ahead. What is the difference between the goals which we have of ART between adults and children. So the most important goal, which is different, which is not there in adults, is that we need to not only cause viral suppression by the optimal ART regimens, but we must promote optimal growth and development of the child so that the child grows as his or her peers, that is for their age, they grow and develop properly. What are optimal ART regimens? Optimal ART regimens means which is the best ART regimen which should be given, or the ARV drugs which should be given to children to not only cause viral suppression, improves quality of life, but also promote growth and development in these children who are infected with HIV. So it should be a more potent, rapidly achieve and maintain viral suppression. The new ARV drugs should prolong the duration of first or second line treatment on whenever we add this drug. And it should also support adherence by reducing the pill burden and should be easy to administer. With the availability of pediatric DTG 10 milligram, these are scored dispersible tablets under NACP. Very soon, these tablets will reach your ART centers and they have to be used in children who are less than 20 kgs, both newly registered CLHIV and also transitioning the old CLHIV who are already on ART to DTG based, pediatric DTG based ART regimens. So what are the advantages of using pediatric DTG? Because this is very important. You should be convinced, each of us who's prescribing this drug should be convinced that yes, this is the best or the optimal ARV which we are giving for our children infected with HIV. So FDA has approved dispersible DTG tablets in children weighing 3 kgs and above and older than 4 weeks. There is documented evidence of that DTG is superior to lopinavir ritonavir. It also reduces the pill burden. As you know, lopinavir ritonavir has to be given 2 times, while DTG pediatric is to be given once unless it's the dosing doubles in TB co-infected children. That also drug-sensitive TB co-infected children. Similarly, in TB co-infected children, when we were using lopinavir ritonavir, we were doing super boosting of ritonavir, increasing even more the pill burden. Well, this will not happen if we are using DTG based ART regimens in our children less than 20 kgs. It is available as a dispersible. Dispersible means as soon as it is put in water, it dissolves. And it's a scored tablet. Scored means it's easy to break into half or split into half. Each pill box of DTG 10 milligram dispersible tablets, DT means dispersible tablets, has 30 tablets. So it's a pill box of 30 tablets. And remember that in children with drug-sensitive TB, we would be giving the dose of pediatric DTG as per body weight twice a day. Otherwise, it is to be given once a day. So just to revise, what is our new guideline which is there? So we have children, first we confirm HIV infection by DBS testing or by serological testing beyond 18 months of age. We treat and stabilize any acute infections and acute conditions and opportunistic infections. And we do all the baseline lab investigations, stabilize the child, and then deciding what ART is based on the weight. Initially, we used to talk about age and weight. It is weight of the child. So any child who is less than 20 kgs would be given AL plus DTG 10 milligrams. Those children who are weight between 20 to 30 kgs would be given ALD, in which the D is dolutegravir 50 milligrams. So the NRTI backbone, that is AL, will remain the same, but because DTG 50 milligram tablets can be given between 20 to 30 kgs, the ART regimen would be AL plus DTG 50. In more than 10 years, if the body weight still remains less than 30 kgs, then the ART regimen would still remain AL plus DTG 50. While if the body weight is beyond, the child is beyond 10 years and more than 30 kgs and does not have any renal disease, we would be putting this child on TLD similar to adults. So most of the adolescents, if their body weight is more than 30 kgs and do not have any renal disease, would be on TLD. So hence, in our program now, if you look at this chart, all our newly diagnosed children living with HIV would be on DTG-based ART regimens, which are the best regimens available for children. The dosage of the ARV in children living with HIV is based on the body weight, and the pediatric dosage chart is available as Annexure 2 in the national guidelines. This is what is the thing. We all request you to please utilize this chart. Please take a printout of this and utilize this to determine what is the body weight. The DTG dosing is given in the last two. This is DTG 5. We do not have this in our program. So please focus on this DTG 10 milligrams core dispersible tablets and its doses as per weight band. I'll discuss about the doses a little later. So now the next thing we've talked about ART initiation in newly diagnosed CLHIV less than 20 kg, sorry. What about transition? What about those children who are already on ART and are not on DTG-based ART regimens? We would like to transition them to DTG-based ART regimens. So we have one case scenario in which children living with HIV with a weight less than 20 kgs have been started on ART, but the duration of ART is less than 6 months. In this, we do not need to do viral load testing, and the transition can occur without viral load testing. What we do is we replace the NRTI with 10 milligram of DTG pediatric tablets. That is, most of the children would be on lopinavir ritonavir, and we just replace the lopinavir ritonavir with the DTG 10 milligram. How do we calculate the dose? The calculation of DTG is as per the drug dosage chart, and it has to be given once a day. The first viral load will be done 6 months after the day the DTG-based regimen has been started, and not the day the child was started on the previous ART regimen or was started on date of ART initiation. The reason is that we have transitioned to a DTG-based regimen, and we would like to know, after 6 months of starting DTG-based ART regimen, what is the viral suppression? So the first viral load will be done 6 months after transition. When you're transitioning these children, please mention in the white card about the date of transition, and put a marker when the first viral load needs to be done, because when these children were started on ART, you would have calculated the date of first viral load testing 6 months after starting ART. But now the date of first viral load testing would depend on the day 6 months after the day when DTG-based regimen has been started. This child has been transitioned to DTG-based regimen. Next viral load monitoring will be as per guidelines, that is 6 months after starting is the first viral load. The next viral load will be 6 months. Thereafter 6 months, that is 1 year after the child has been transitioned to DTG-based regimen, and then annually or yearly, once in a year. Scenario 2 of transition is where the CLHIV with weight less than 20 kg is already on ART for more than 6 months. In this, we need to do a viral load testing and see whether evidence of viral suppression is there or not. Viral load which has been done in the last 3 months can be taken for the transition decisions, and you do not need to repeat viral load again in these children. So the result of the viral load can be only 2. If it is suppressed means the viral load is less than 1000 copies per ml. Then we transition these children to DTG-based pediatric DTG 10 milligram based ART as follows. AL plus LPVR will be transitioned to AL plus DTG 10. ZL plus LPVR children would be transitioned to ZL plus DTG 10 milligram regimens. The calculation of the dose of DTG will be as per the pediatric drug dosage chart, which I have already shown. Please utilize them. But what do we do if the viral load is more than 1000 copies? So if the viral load is more than 1000 copies, we do 3 months of enhanced adherence counseling while continuing on the same regimen which the child was on. We do a repeat viral load when adherence is more than 95% over 3 consecutive months. And depending on this repeat viral load, we do transition of the child to a DTG based 10 milligram based ART regimen with SASIP guidance. So remember that in all children where the viral load is unsuppressed, after doing the enhanced adherence counseling, the repeat viral load report, a summary has to be sent to the SASIP or the pediatric COE to get opinion on what should be the next regimen. What regimen is this child going to be started on in? So let's just summarize whatever we have understood till now. So in this table, the whole summary of what we have understood in the last 2 slides is explained. So if the child is on AL plus LPVR and the child's viral load is suppressed, that is the child's viral load is less than 1,000 copies, we just replace the LPVR with DTG 10 as per body weight, and the child would be on AL plus DTG 10. Now, if the child was unsuppressed, was given enhanced adherence counseling, and despite enhanced adherence counseling for 3 sessions, 3 months, repeat viral load still showed unsuppressed, that is more than 1,000 copies, the transition would depend on the HP level. If the HP was more than 9 grams, then the child would be on ZL plus DTG 10. If the HP was less than 9 grams, then we would continue the AL and add DTG 10. So this child, even though the child has got suppressed viral loads, would be continued on AL plus DTG 10. But remember that this child is anemic. So please do evaluate this child by a pediatrician and get iron supplementation if the child is anemic because of iron deficiency anemia. Remember that both these unsuppressed scenarios, in this case, guidance has to be taken from PCOE and SASIP. It cannot be a decision taken by the SMO or the medical officer of the ART center. A SASIP referral has to be given and guidance has to be sought. If you have a pediatric COE and you're in contact with the project director of the program director of the PCOE, please discuss this case scenario and take it in writing. What should be the regimen for this child? Now, if the child is on ZL plus LPVR and has suppressed viral loads, then it's simple. We just replace the lopinavir, ritonavir with a DTG 10 milligram, and the regimen would be ZL plus DTG 10. But if this child whose viral load is unsuppressed and has been given 3 months of enhanced adherence counseling, and the second repeat viral load is also unsuppressed or more than 1,000 copies, then we need to find out, one, whether the child was previously exposed to abacavir. If the child was not previously exposed to abacavir, then we will shift this child to abacavir, lamivudine, and DTG 10. If the child has previously been exposed to abacavir and because of some reasons we cannot give abacavir, then we would be continuing with the ZL NRTI, and DTG 10 milligram will be added instead of lopinavir, ritonavir. Even for this transition, we need to have guidance from PCOE or SASIP referral. Only then can this transition be done. So now let's just understand what are the ARV drug dosing for the new drug which has come, DTG 10 milligram. So the child who's between 3 to 5.9 kgs would be given 10 milligram of DTT, dispersible tablets of DTG, half a tablet once a day. 6 to 9.9 kgs would be given 1.5 tablet once a day. 10 to 13.9 kgs would be given 2 tablets of 10 milligram DTG tablets once a day, and 14 to 20 kg body weight children would be given 2.5 tablets of DTG 10 milligram. If you compare with the dosage of abacavir lamivudine 60/30, which is given twice a day, except for this dosage, the dosage remains the same. So remember that in children who are 3 to 5.9 kgs is given half a tablet. Otherwise, the dosage of abacavir lamivudine 60-30 milligram, which is given twice a day, it is a tablets. The number of tablets is going to be the same. Similarly, for the doses of ZL 60-30, which is again given twice a day, the number of tablets beyond 6 kgs remains the same. So DTG 10 milligram is given once a day, 1.5, while abacavir lamivudine 60-30 for beyond 6 kgs, between 6 kgs to 9.9 would be 1.5 tablets, and ZL dose for 6 to 9.9 kgs would be 1.5 tablets. So the dosage from 6 to 20 kgs for these, except the times it is to be given, the number of tablets are going to be the same. Only this red circle which I've shown, that is a dose which is different for from the other tablets like abacavir lamivudine pediatric and ZL pediatric. What would be the DTG dosing for children with HIV TB co-infection? Remember that only in drug sensitive TB do we double the dose. So DTG dose will double only when we are giving in along with rifampicin, because rifampicin has interaction with DTG and rifampicin reduces the DTG blood levels. Hence, when you're giving it along with rifampicin, we need to make it twice a day so that it maintains its antiviral activity. So for children with drug sensitive TB, the dosage of DTT 10 milligram DT tablets between 3 to 5.9 kgs would be half tablet twice a day. 6 to 9.9 kgs would be 1.5 tablet twice a day. 10 to 14.9 would be 2 tablets twice a day. 15 to 19.9 kgs would be 2.5 tablets twice a day. And those children who are more than 20 kgs would be put on a DTG 50 milligram tablet twice a day. Remember that this DTG tablet, which is to be made twice a day, has to continue for 2 weeks after the last dose of rifampicin. And the next important point which we must remember is that there is no need to change the dosage of DTG in drug-resistant TB cases. Let's understand what are the counseling messages which we need to explain. What are the counseling messages which we need to give to the caregiver and the CLHIV when now that we are starting a new pediatric drug? So first, of course, is explain the need for lifelong ART and importance of adherence and viral suppression. Next is explain what are the benefits. Why are we starting this new drug in children? Because it's effective. It's more effective than the previous drug, which was lopinavir ritonavir. It is safer. It is easier to administer. Lopinavir ritonavir syrups had to be kept in the fridge. The lopinavir ritonavir pellets needed to be taught. The caregiver needed to be told how to administer the pellets. But DTG dispersible tablets are easy to understand and easy to administer. Explain what are the rare side effects: insomnia, fatigue, headache. Most of the children do not have this. This is seen more in adults, but we would like you to give us a feedback that what were these side effects reported by the children in whom you have started pediatric DTG. Rash also in adults, a few cases were reported that there was allergic rash due to DTG 50 milligrams or a TLD tablet. So we would also request you all to explain to the parents in which you're starting DTG 10 milligram, though fatigue and headaches are not easy to explain, especially in smaller children, but in a child who can understand and who's going to school would be able to explain if they had these kind of symptoms. And rash, of course, should be reported. Important to counsel that report immediately. Explain about weight gain due to DTG. This is also one of the very important side effects which have been noted. So in children, We need to counsel the caregivers that there should be adequate exercise and nutritional counseling. Children are very fond of fast food and fried food items, and hence nutritional counseling, because they are susceptible to gaining more weight and towards overweight issues, maybe sometimes obesity also. So this is an important counseling which needs to be done. Explain how to give the drug. So there are 10 steps to be followed. I'll be discussing it in the next slide. Specify to the parents that the dosing is weight-based and dose will change as the child gains weight. Next is fix the timing of giving the drugs. DTG has a lot of interaction with various drugs. So if you remember, most children would be on iron supplements, calcium supplements, maybe taking some antacids off and on. So you have to explain that DTG should be taken 2 hours before or 6 hours after taking these supplements or multivitamin syrups which the child is on. And you must explain to the parents that if some new medicine has been added by a pediatrician, they should come and inform the medical officer and find out if this has some interaction with DTG. Fixing the timing of drugs is very important. What time should DTG be given? What time should iron be given? What time should calcium be given? These are very important counseling messages which need to be discussed and conveyed to the caregiver. So how is DTG 10 milligram to be given? So DTG 10 milligram tablets can be dissolved. It is usually dissolved in drinking water in a clean cup. It is best to use drinking water to dissolve these tablets. Some studies have shown that it can be given in breast milk, but the best efficacy comes with drinking water. So let's keep it as dissolving in drinking water. Take required number of DTG tablets depending on the weight of as per the pediatric dosage chart, and add a measured amount of water in the cup. So what is the amount of water you need to add? So for half to up to 3 tablets, 1 teaspoon or 5 ml of water would be enough to be added in the cup or katori. When the tablets are 4 to 6, actually 4 to 6 tablets, which is not going to be very common because our dosage doesn't go beyond 2.5 tablets. But if there are 4 to 6 tablets you're giving, then you need to put 2 teaspoons of water. And if you're going to be giving along with AL and ZL, so you can, if the child is on AL plus DTG 10, you can dissolve the AL and DTG in the same cup if the AL and the ZL are dispersible tablets. So ask your doctor. You have to explain to the caregiver very clearly that the abacavir lamivudine tablets which you're giving are dispersible tablets and can be given with DTG. Or if the AL tablet at present, which is the pediatric tablet, is not a dispersible tablet, then it would have to be dissolved separately and given separately, cannot be given along with DTG. ZL is a dispersible tablets and can be given. So if you're giving ZL along with DTG 10, then we need to add 4 teaspoons of water to dissolve both the tablets 10, DTG 10 and the number of tablets of AL. So once we've understood what is the amount of water, now this is a small cup which has 5 ml, 10 ml, 15 ml. Most of the pediatric patients have this cup at home because they are prescribed syrup, paracetamol or syrup, cough syrups which have this cap. So if this cap is available, the parents can use the cap to measure the ml. Otherwise, measuring a normal teaspoon would be enough to measure the amount of water. Remember that now let's go back. So we added the amount of water on top of the tablets. So we've taken the tablets in a cup, we've added the amount of water in it. We should now just swirl the solution so that the tablet disperses or dissolves properly. This solution should be given immediately within 30 minutes of mixing. The tablet becomes ineffective if this solution is given beyond 30 minutes. So please don't tell them to prepare the tablet and then give food. And then after, maybe the child may take more time to eat food and it goes beyond 30 minutes. So the timing should be that the child is eating its food, and by the time the child is just about to finish the food, the solution should be prepared by the caregiver. After once this whole solution has been given, after that, there may be some amount of medicine left in the cup. So small amount of water should be added to that cup. And this should also be given so that the complete dosage of the drug is given. DTG dispersible tablets can be swallowed whole. 1 tablet at a time should be given, and this should avoid choking. Remember, only children beyond 5 years of age can swallow tablets. Any child who's less than 5 years of age should not swallow tablets. They should be given dispersing it or dissolving it in water. Score DTG tablets can be split with dry and clean hands, and this leftover half tablet needs to be returned to the bottle. So just wanted to revise the DTG interactions which are there. So tegretol or carbamazepine is a very common anticonvulsant which is given in children. So remember, there is interaction and DTG levels are reduced when given along with this anticonvulsant. So we need to do the make the dose of DTG twice daily, or a better option is to use a different anticonvulsant. So what anticonvulsants can be given? Valproate is a very good anticonvulsant, or lamotrigine. So this is a discussion which needs to be done with the pediatrician, saying that this child is going to be put on DTG. So we would like you to change the anticonvulsant. Same thing is with phenytoin and phenobarbital. Children who are on these drugs need to be shifted to a different anticonvulsant. This interaction I told you with iron and multivitamins, I've already spoken about it. Interaction with rifampicin has already been spoken. So now let's do a little small exercise. This is the drug dosage chart. I hope it is visible, the drug dosage chart. I just wanted you all to do a prescription writing practice for ART initiation on DTG based regimens. So first question is 6-year-old, weight 13 kgs, 8 grams HP, CD4 is 500 cells per millimeter cube. Please tell me what is the prescription for this child. Any answers?
Participants are requested to please type in the chat box. Ma'am, the answers are AL, ALD.
Yeah, but I wanted the dose. ALD, everybody knows all our children are going to be on ALD less than 20 kgs, whether it is DTG 10 or DTG 50. ALD is a very simple answer. I would like you to tell me the dosage. The aim of this prescription was to tell me what is the dose of DTG you'll be giving. So I'll solve the first question so that you all know what I'm trying to explain, ask you all. So it will be AL plus DTG 10. AL 60/30 would be 2 tablets twice a day, while DTG 10 would be 2 tablets once a day. And you need to put this child on hematinic syrup because the HP is 8 grams. Also get the child evaluated by a pediatrician to find out what is the cause of anemia. All children with anemia don't always have iron deficiency anemia. We need to rule out other causes of anemia also. So my next question is 7-year-old, weight 19 kgs, female child, 9 grams hemoglobin, CD4 300 cells, no OI. Can you please give me the prescription for this child? Prescription means the dosage also. So the answer for this is, somebody has written ZLD. Why should ZLD be given? It is an initiation, right? AL plus DTG 10, AL 60/30, 2.5 tablets twice a day, DTG 10, 2.5 tablet once a day. Tablet cotrimoxazole single strength, 1 tablet once a day because the CD4 is 300 cells. Tablet ferrosal folic acid, 1 tablet once a day. Let's see the third thing. 3-year-old child, 9 kgs, HP not available, CD4 400. What would be your prescription? So AL 2.5, yes, good. So the second people have answered properly. Thank you so much for participating and putting it in the chat. Can you please give the answer for the third question? So in a 3-year-old child with 9 kg weight, 9 kgs, we will give AL 60-30, 1.5 tablet twice a day, DTG 10, 1.5 tablet once a day, cotrimoxazole syrup 5 ml once a day. All children less than 5 years of age have to be given cotrimoxazole syrup up to the age of 5 years. So the last is 4.5-month-old infant was diagnosed HIV infected through DBS testing. Weight is 4 kgs. What prescription would you give? What regimen? What is the dosage? Okay, thank you. People have answered. Participants have answered the third question also. I would like you to look at this dosage chart and refer what is the dose for DTG and what will be the dose for abacavir lamivudine 60-30. Because there's some confusion in that in one of the answers which has been given. Okay, so the answer would be, so AL DTG 10 is the ART regimen and AL 60-30 is 1 tablet twice a day. If you look at this 60-30, less than between 3 to 5.9 is one tablet morning, evening, twice a day, while DTG 10 milligram is 0.5 milligram once a day. This is the only time when the dose is just different. And syrup cotrimoxazole is 2.5 ml once a day. Thank you so much for participating. I hope it's now clear how we need to utilize this pediatric dosage chart while writing the new ART regimen for children less than 20 kgs weight. So once we've started the child on DTG based ART regimen, we need to monitor the child. So what are the important things? This is normal. Previously also you were monitoring. But yes, growth and nutrition, we need to monitor more because DTG has one side effect called weight gain. And the second is we need to calculate the ARV dose as per weight. And always check when the child gains weight. If the child goes beyond 20 kgs, between 20 to 30 kgs, we would not be giving pediatric DTG. We would be shifting this child after to a DTG 50 milligrams. So this is important that we need to calculate the ARV dose as per weight and maybe shift the child from pediatric DTG to DTG 50 milligrams once the child goes beyond 20 kgs. The last slide, I think, is this, that weight gain is a very common adverse reaction to DTG. Hence, growth monitoring becomes imperative. And these are the growth charts which are available, annexures 7 to 12 in the national guidelines. Weight for age, height for age, less than 5 years, and beyond 5 years, we have the IAP BMI index charts. In these BMI index charts, these red lines are there. So in more than 5 years of age, it's available both for boys and girls. These red lines are there. So if the child is gaining weight and goes beyond this orange line or on this orange line, that means this weight gain is beyond what is in the healthy pattern, and this child is maybe gaining weight towards overweight and maybe because of DTG. The answer is not to change DTG. It is to explain and explain to the caregiver that the diet modification has to be done and exercise routine has to be implemented. So monitoring is very important, and diet and nutritional counseling is also very important. That was my last slide. Thank you so much. Over to Shweta. If there are any questions, we'll answer at the end, I think.
Yes, ma'am. Yes, ma'am.
Okay.
I now request Reshu ma'am to please continue the session. Ma'am, can you please stop sharing your screen?
Yeah, yes.
Thank you, ma'am.
Yes.
Reshu, can you please share your screen?
Yes, yes. Is it visible?
Yes, ma'am. The presentation, please.
Yes. And
Yes, ma'am.
fine now, Shweta?
Yes, ma'am.
Okay, thank you. So thanks, Dr. Chinmay and Dr. Rohini for a very comprehensive presentation. And I think Dr. Rohini has discussed most of the guidelines which are applicable for the children who would be initiated or the children who would be transitioned to DTG-based, the 10 milligram dosage of DTG. So now I think we'll discuss some of the specific scenarios based on the practical situations in the field. So the first scenario is, just give me a second. Yeah. So if there are like kids where the viral load has not been done in last 3 months, and currently if the viral load is not available and the lopinavir ritonavir stocks are exhausting or are not sufficient to wait for the viral load test or for the viral load results, in such cases, what should be done? So in such cases, transitioning to DTG-based regimen with the existing NRTI backbone has to be done immediately. And please note here, because we do not know whether the existing NRTI backbone and the previous or the current ART is working or not working in this situation. So we will shift this kid on DTG-based regimen with the existing NRTI backbone. In such cases, however, we'll have to do enhanced adherence counseling. And as Dr. Rohini explained, a very specific counseling has to be provided to the caregiver of these children so that they are adherent to DTG-based regimen. And the viral load test has to be done after 6 months of transitioning to DTG-based regimen. Coming to the next scenario, where there might be some children who are virally unsuppressed and undergoing enhanced adherence counseling. But if you don't have sufficient stocks of lopinavir ritonavir again to wait for the EAC completion, then what has to be done? And I think this question was also posted in one of the WhatsApp group also. So in such situation, again, we will shift the child to the DTG-based regimen with the existing NRTI backbone. And we need not wait for the EAC to complete in such situations because there is a apprehension that lopinavir ritonavir may get stocked out. In such cases, however, enhanced adherence counseling is very critical because the child is unsuppressed on the current ART regimen. So there are some issues because of which the child is not adherent to the treatment, and we need to address those issues, identify those issues and address those issues so that we can have the optimum benefit of DTG-based regimen. And again, in such cases, the viral load test has to be done after 6 months of transitioning to DTG-based regimen. Coming to the next scenario, what to do if the child is on second line ART or the lopinavir containing ART and virally unsuppressed? And this question is asked in the chat box also. So in such cases, what we are doing is we are transitioning the child to a DTG-based regimen with the existing NRTI backbone. Usually these will be the kids who are like basically on ZL lopinavir ritonavir currently. So these children are to be continued on the existing NRTI backbone with the pediatric DTG in an age-appropriate dosage. Enhanced adherence counseling is to be provided, and again, we need to address the barriers for the adherence, and this piece is very critical. So please do a very thorough review of the child and provide the solution. So when we say enhanced adherence counseling, it does not just means counseling, but it also means that we need to be really solution oriented and provide support to the child for ensuring adherence. Now, even this is being asked, like, what is the reason or what is the rationale of continuing the existing NRTI backbone with DTG? So obviously for the pediatric ARVs, the options are very limited. And in most of the cases, when we talk about unsuppressed viral load, in most of the cases, the reason is suboptimal adherence. And since we are not doing drug resistance testing in our program, we really do not know whether these children are really failing on the current ART regimen or not. So given the superior efficacy of DTG and also the benefits in terms of improving the adherence over other ARV drugs, this regimen is assumed to have like no advantages in terms of ensuring better adherence, because it would be like it will be having a more simplified dosing schedule and less pill burden, as Dr. Rohini discussed, that it's like once a time, once daily, and usually the pill burden is very low as compared to the previously used regimens. Then these are easy to administer as compared to the pellets or granules which we were using for lopinavir ritonavir based regimen, and usually that was also one of the reasons for poor adherence or suboptimal intake of the drug. It has better palatability, and it is supposed to be having a strawberry cream flavor, which is like comparatively more liked by kids. It has better tolerance in terms of the side effects. The side effects are very minimal with DTG, and that's why, because of the side effects, children are very unlikely to discontinue this drug. And obviously, this has a very robust virological response and a very high genetic barrier for resistance. So that's why, considering all the benefits of DTG and whatever literature is available currently, because for the children who are less than 20 kg, a lot of studies have not been done. But what we know, in the children more than 20 kg and in adults, that most of the times, even with a partially active NRTI with DTG based regimen, it really works well, provided the adherence is good. So that's why after a lot of discussion and deliberations, and given the benefits of DTG and also the limited options which are available for children, NACO and the TRG has taken this decision to continue with the existing NRTI backbone along with the pediatric DTG tablet in an age appropriate manner. Now, does pediatric DTG require any specific monitoring? So the routine monitoring has to be done as per guidelines, as was described by Dr. Rohini. And here it is very important to do the initial viral load after 6 months of initiation or transition. So whenever a child is put on a DTG-based regimen, the initial viral load or the first viral load after DTG has to be done after 6 months. And in all the children who are being newly initiated on ART, this viral load has to be done at 6 months, 12 months, and then annually. And for the children who are transitioned to DTG-based regimen, for them, it has to be done at 6 months, 12 months, and then annually for first line, and every 6 months if the children is on second line or third line ART. Height and weight monitoring is very important, because with DTG has a very robust response. And usually, the studies shows that the children really respond very well to DTG. So there might be immune reconstitution, child might be gaining some weight, they might be gaining height, and that's where their dosages may need to be adjusted. So please do keep monitoring the height and weight of the babies. Also, it is important to do all the routine lab investigations along with the blood sugars. And in a while, we'll discuss about the adverse effects also. But these are the protocols or the guidelines which are mentioned in the national guidelines. So, those protocols for monitoring have to be followed for all CLHIV on pediatric DTG as well. So if a child is started on an age-appropriate dosage for pediatric DTG, that is 10 milligram, what should I do if the child gains weight more than 20 kg? So in such cases, if the child gets weight more than 20 kg, in such cases, we will shift the child to a dolutegravir 50 milligram tablet. So from this chart, you can see that if the child is having a weight less than 20 kg, we will give a age-appropriate dose of DTG 10 milligram. But if the weight increases to more than 20 kg, then we will shift the child to DTG 50 milligram tablet. Now, earlier we were using a criteria of 6 years. So is that criteria applicable now also with 20 kg weight? So now, like with as a part of the simplification of the process, NACO TRG has decided to get away with this criteria of age for the children who are less than 20 kg, who are less than 10 years of age. So all, I mean, as per the WHO guidelines and as per the national guidelines, the definition is like till 10 kg, till 10 years of age, we consider the child as children. And then if the child attains the age of 10 years, then beyond that, the child is considered adolescent. So the first criteria or the first cutoff is basically the age less than 10 or more than 10. And if it is more than 10, obviously we will follow the adult and the adolescent guidelines. And if the age is less than 10 years, in those cases, we will just follow the criteria of weight. And if the weight is less than 20 kg, then DTG 10 milligram tablet has to be used. And if the weight is more than 20 kg, in those cases, DTG 50 milligram tablet has to be used. The other piece is, can DTG 50 milligram and DTG 10 milligram be used interchangeably? So the big answer is no. So DTG 50 milligram is a film-coated tablet, and it is recommended for adults, adolescents, and children weighing more than 20 kg. DTG 10 milligram is a dispersible tablet, and it is recommended for the children weighing less than 20 kg. And when we see the strengths of these two drugs, so the 50 milligram tablet of DTG adult or DTG film-coated tablet does not actually match with the strength of the pediatric 10 milligram. So actually, DTG 50 milligram in terms of the strength is equal to 3 tablets of dispersible 10 milligram DTG pediatric formulation. And this is because the pediatric 10 milligram is a dispersible tablet and it is comparatively better absorbed. And that's why we don't see a dosing of or a ratio of 1:1 between DTG 50 milligram and DTG 10 milligram. So these drugs should not be used interchangeably. Can AL be administered in same solution with pediatric DTG? And Dr. Rohini already explained about this. So yes, you can use it in the same solution whenever, like once a day, the child would be taking DTG with AL, and the second time it would be only AL if we are using a 60/30 tablet. So in such cases, when DTG has to be given along with AL or ZL, in such cases, it can be prepared in the same solutions or at one go. Can DTG 10 milligram be mixed with other liquids other than waters, such as juice, breast milk, or food such as yogurt or porridge? So usually it is recommended that it has to be mixed with the clean water to be given to the child. But however, in a case if the child is not able to take water, in such cases, it can be given with other liquids or foods such as juice, breast milk, yogurt, or porridge. And again, in such scenarios, it has to be mixed with very small quantity of the food so that child is able to take the entire dosage at one go. Can pediatric ART be repeated if the child vomits? So in case if the child vomits within 30 minutes of taking the drug, in those cases, full dose of the ART can be given. But if it is beyond 30 minutes, then there is no need to repeat the drug. Now coming to the timing of the DTG-based regimen. So can DTG containing ART be given at any time of the day? Yes, any time of the day can be decided based on the convenience. So you can discuss with the caregiver, like whatever time would be convenient for the child. So, and usually if the children are school going, it has to be like adjusted with their schedules. But remember that it has to be taken at the same time every day. So this piece is very important part of the counseling. Whenever you are deciding and telling the caregiver or the parents like when to take ART, just fix up a time according to the schedule of the child and the caregiver so that it is convenient for them, but ask them to maintain that time every time they take the drug. And if the child is on twice daily regimen, suppose AL 60/30 or ZL has to be given, then we have to ensure that there has to be a 12 hours difference between the two dosages. Are there any adverse effects of DTG? So for DTG, in most of the cases, it is very well tolerated. And in all the clinical studies which have been done in children, there have been no evidence that the children have been discontinued because of the adverse effects of pediatric DTG. However, like as with all ARVs, there could be some possible side effects, which could include insomnia, fatigue, and headache. But again, these are very infrequent, but it is always good to monitor children for these side effects, especially insomnia, fatigue, and I mean, obviously headache would be very difficult to know in children. The other piece is around the weight gain. So because the most important trial which was done for pediatric DTG or DTG 10 milligram or 5 milligram was the Odyssey trial. And in that trial, there were no cases or no children where excessive weight gain was reported. So as per studies, weight gain has not been reported, but it is always good to monitor all our kids for weight gain. And anyways, like to decide the dosages, we have to do a routine or a regular weight monitoring for all the kids. So it is very critical to keep doing that, and that would also help us to understand in case if kids do not respond well. But as of the data which is available, no cases have been found of excessive weight gain. Also for hyperglycemia, though there have been some reports, some trials have reported that there is hyperglycemia associated in adults. Again, for children, nothing of that sort has been documented or reported so far. But again, I'll say it is always good to monitor the children for blood sugar levels as well as we do in adults. Can the child be given other medicines in addition to pediatric DTG? So yes, usually DTG is very well tolerated and it does not have a lot of interactions with other drugs. So most of the drugs are very well tolerated, but as was discussed, especially if the child is on TB rifampicin containing TB treatment, then the dose of DTG has to be increased to twice daily age appropriate dosage, and this dosage has to be given till 2 weeks after completion of rifampicin containing ATT. So this piece is very critical, and this is one of the very critical or very important drug interactions for pediatric DTG. And you all have been doing this for adults as well as for children more than 20 kg. So this has to be followed even for the younger children. Also for iron, calcium, magnesium, and calcium containing medicines, because at times the children would be on these supplements. So these supplements, they have interactions with DTG, and if they are to be given along with DTG based ART, then at least a proper time interval has to be maintained, and DTG should be given at least 2 hours before or 6 hours after such formulation so that DTG is absorbed properly. Then Dr. Rohini already spoke about the anticonvulsants. So if the kids are on phenytoin or phenobarbital, then these are to be avoided. So it's always good to discuss with the pediatrician for alternative anticonvulsants. And if that is not possible, then we'll have to think about the alternative ART regimens as well. But these things need to be discussed and thought through. The other question is, can IPT be given along with pediatric DTG? Yes, so there are no contraindications for isoniazid. So isoniazid as per age and weight has to be given to all the children as per guidelines, and it can be given without any hesitancy. Coming to the logistic piece, so there might be some ART centers there where lopinavir ritonavir stocks may last for a couple of months. So they might have sufficient stock. So in such cases, when should the transition to pediatric DTG be started? So in such cases, all new children should be initiated on DTG based ART with immediate effect. So because now with the availability of the DTG, we do not want our children to be exposed to lopinavir, and then after some time we should be shifting them to DTG. So from with the immediate effect, as soon as the DTG, pediatric DTG is available at your centers, all new children should be initiated on DTG-based ART. For the children who are already on ART, transition has to be planned in a phased manner if you have sufficient stocks of lopinavir in consultation with the SACs. And also keep in mind that you should keep some stock in reserve for the children who might need lopinavir ritonavir after advice of CESEP or pediatric COE, and just see if you have some long expiring stock that can be kept for reserve purposes for such case scenarios. So NACO is also working on the job aids for healthcare staff, and then also the frequently asked questions for the caregivers. And NACO would also be sharing with you Excel format for comprehensive monitoring of CLHIV on pediatric DTG, so that because obviously this is the most robust regimen which we have in our armament for the kids, and we really don't want that children should be unsuppressed or failing on DTG based regimen. So it really needs a very comprehensive, very rigorous and systematic monitoring, and that's why NACO would be sharing this format with you with access to SACs and PCOE, so that a timely intervention can be done if there is unwanted unsuppression which is seen in these kids. So this format would be shared with you. And I think for the subsequent slides, may I ask Dr. Purnima to continue?
Yes, ma'am. Can you please allow me to share my screen?
Sure.
Shweta.
Yes, ma'am.
Shweta, please unmute Dr. Purnima.
I will do that, ma'am. Kiran sir, can you please help with that? Make Dr. Purnima ma'am co-host, please.
Just a minute, ma'am.
Yeah.
Yeah,
Ma'am,
thank
can you
you.
unmute?
Yeah.
Yeah.
Thank you, Shweta, and thank you, Dr. Rohini and Dr. Reshu, for the wonderful session covering all the technical as well as the operational aspects. Shweta, may I please request you to go back 2 slides prior to these, where
Sure,
there's rules of,
Yeah.
Thank you. Thank you so much. So as Dr. Rohini ma'am and Dr. Reshu also explained about all the technical aspects, where how the transition has to be done, what is the importance of counseling, monitoring of the patients, everything, as well as the operational, where the viral load testing and regular monitoring has to be done by the ART center staff, as well as regular monitoring by the SACS officers, ensuring smooth transitioning of the patients. So here it is very, very important that we understand that what exactly is the role of PCOE, SASAP, as well as the SACS. And when I say PCOE and SASAP, at many places, Dr. Rohini as well as Dr. Reshu mentioned that the patient who are unsuppressed, we have to seek guidance from PCOE and SASAP, and as per their guidance, then accordingly we have to transition the patient to the recommended regime. So it is the role of PCOE and SASAP to regular and systematically monitor the CLHIV who has been initiated and transition to pediatric DTG, which is DTG 10 mg, and also mentoring the ART center, because this is a new drug, and this all the children less than 20 kgs will be initiated on, the majority of the children will be initiated on and a transition to DTG 10 mg based regimen. So it is very, very important that we monitor these patients, as well as PCOE and SASAP support the ART center staff for support the ART center staff if there are any challenges or issues with respect to the transitioning or initiation of the pediatric patients. And regularly review the unsuppressed cases, and SACS has to ensure if there are any challenges with respect to the SASAP reviews at any level, please intervene and please see if there are challenges where NACO can help, let us know. Otherwise, please ensure that the SASAP reviews are happening on a regular basis. And the most important part, which is SACS, with respect to the operational aspect, the ART center will need your help, the handhold support in the whole transitioning. You have to ensure that all the ART centers are maintaining their list, the due list for viral load testing, the patients who are actually planned to be transitioned to DTG 10 mg based regimen, and what exactly is the transitioning plan? Is there any challenge which they're facing with respect to the operational aspect? How SACs can support them? And if there's anything which NACO needs to, where NACO's intervention is required, please do let us know. Also, when we are talking, the DTG 10 mg will be available from today. At some of the states, it has already reached, some of the states it is reaching. So maybe in a day or two, all the states will have stock of DTG 10 mg. Now, all the SACs nodal officers, CST nodal officers, please ensure that there is enough stock of DTG 10 at all the ERT centers. And if going forward, you will be getting more stock. Gradually, within 10 days or 15 days, you'll start getting more and more stock. So it is important that you monitor this stock on a weekly basis and see if there are any inter-ERT relocations required. And the national level relocations we will be handling from the SCM team from NACO's side. Next slide, please. Shweta, next slide, please. Thank you. So this is the PCOE linkage plan. So all the states may please take a note of which PCOE they are linked to. There are 7 PCOEs in the country. Please take a note where you are actually linked and where you have to refer your patient for SASAP. And ensure that all the patients who are unsuppressed are, you seek suggestions, recommendation from the SASAP and PCOEs, and accordingly you have to transition the pediatric patients. So I'll stay here for some time so that you can take a note of your respective PCOEs, and these slides will be shared with all the states later, so you can refer it later as well. So I'll just pause here for a minute. So, okay. Now going forward, because DTG 10 is newly introduced, and when we are talking about monitoring this patient, transitioning this patient, we have to record also. So for recording purpose, the MPR has been updated, which you'll be receiving very soon, the new MPR tool, where DTG 10 mg has been included. The weekly drug report, which you share to the SCM team of NACO, that has been updated with DTG 10 mg. As well as the Soch portal has been, you can see DTG 10 mg and you can start dispensing through Soch. Going forward, I'll show you a screenshot how it will appear on the Soch portal and how you have to dispense. And as Dr. Reshu also mentioned, that we are working on some job aids, which you will be receiving very soon, which will be ready reckoner for the ART center staff with respect to DTG 10 mg for children less than 20 kgs. So now, it is, when we talk about weight of a child, it is extremely important that all the ERT centers have a weighing machine. So Dr. Rohini and Dr. Reshu in their presentations, they kept on saying that if the patient is this much weight, you have to give this regime. But it will be only possible when we have a weighing scale at the ART center. So please ensure that all the ART centers have weighing scale, all the SACs officers, it is a request, please check if the ART center doesn't have a weighing scale, please ensure that they have one. And as per the weight band of the child, the regimen should be then decided. So if a child is, suppose less than 20 kgs and during the next visit becomes more than 20 kgs, then accordingly the regimen should be given to the child. So ensure that the weight monitoring is happening every month, every visit when the child is visiting the RT center. Accordingly, the regimen should be given. Moving on to the next slide. Next slide, please, Shweta. So this here you can see a screenshot of the Soch module, where you can see that in the prescription mode, DTG 10 mg, there are 3 circles. If you go to this dispensation, then the prescription mode, you'll see DTG 10 mg and it can be dispensed. So the quantity you can manually enter because it is as per the age and weight band. Like other pediatric drugs you were doing earlier, it is same. So you can mention the number of tablets which has to be dispensed to the child. And accordingly, this can be entered in the Soch. Next, please. Yeah. So here you use in the regimen mode, you can see that ZL and DTG. when we are in a regimen mode, when we are given, it is DTG 10 mg, you can see how many tablets you have to give, and a ZL 60/30, how many tablets you have to give. So here, according to the regimen, you can dispense the medicines to the patient. So these are 2 screenshots from the SOCH. This is already live and active. And as soon as you receive DTG 10 and start dispensing, you can start using this for dispensation. So apart from this, I would also like to mention that there is another session which is specifically being planned for the SASAP related issues with respect to the CLHIV and the coming week. So it is my request that all the ART centers, specifically the ART plus, COEs and PCOEs, please attend this session. This is a very, very important session for all the SASAP related queries and issues if you're facing that can be discussed. So we'll be sending the communication very soon. And please do ensure, SACS officers, please do ensure that the ART centers and ART plus centers and COEs are attending this session. So thank you. Thank you very much.
Thank you
Shweta,
so
over
much,
to you.
ma'am. Yes, ma'am.
Question.
Yeah, here are the questions from the chat box. We can take up these and then we'll give access, mic access to everyone. Is that okay?
Yeah, sure.
What will start if age is less than 10 years and weight is more than 30 kg?
So Shweta, I answered this question in the chat box that for
Okay.
tenofovir, we need the age to be more than 10 years and 30 kgs. So we can only shift this child to TLD if once the child is more than 10 years and 30 kgs. If the child is less than 10 years, it will remain as ALD.
Thank you, ma'am.
Abacavir, lamivudine plus DTG 50 milligrams.
And whenever such kind of transitions are done, it is always advisable to do a viral load test. So if the child attains a weight of 30 kg and you want to put child on tenofovir, then a viral load has to be done before shifting the child to tenofovir based ART.
Ma'am, most of the things must have been covered throughout the session. I'll just read through the questions and you can let me know if it has already been covered. Unsuppressed transition will be labeled as second line.
It depends on whether
Yes.
the patient was on first line previously or second line previously. That depends on what was the previous regimen.
Dr. Neetu, yeah.
If the child was on first line as now unsuppressed transition, then it will be second line. If the child was on second line ZL plus LPVR, then you're shifting. So this opinion, whether it is second line or not, I think the SASIP should be clearly mentioning it in their response.
Dr. Neetu Gupta had raised this question during the slide on counseling for caregivers. And it says this means we have to give failing ARV drug in unsuppressed
I
viral.
explained that, yeah, we discussed that.
Right. Rationale for using alternate first line or substituting only DTG for unsuppressed case with hemoglobin less than 9 grams.
No.
This has been addressed, I think.
Addressed. Viral load
Yeah.
test is not available for many months and children on lopinavir, ritonavir not receiving drug for 3 months. What should be done?
This has been addressed. So you immediately shift them to the NRTI with the existing NRTI both backbone and DTG, and then do a viral load after 6 months.
Okay, ma'am. Few children on ZL DTG lopinavir ritonavir, AL DTG lopinavir ritonavir, and DTG lopinavir ritonavir as second line recommended by PSASIP. What is to be done in such cases?
So they are already on a DTG based regimen. So they don't need, nothing needs to be done on this. We have to continue on DTG. Basically, what is the aim of this session today was that those children who are not on DTG based regimen need to be transitioned or initiated on. Those who are newly diagnosed have to be initiated on DTG based regimens, and those who were not on DTG based regimen have to be transitioned to DTG based regimens. These patients are already on DTG based regimens, so we do not need to make any changes in this.
Okay, how superior is DTG from lopinavir ritonavir for children? And there was a request for sharing the literature. It's WHO HIV guidelines 2021. Next question, what will be the regimen for multi-NRT?
Just to add here, so basically the study which actually led to the adoption of pediatric DTG was the Odyssey trial, And as per that trial, in terms of the efficacy for viral load suppression, DTG was found to be like 11% more efficacious. And you can look into these resources along with the WHO guidelines.
What will be the regimen for multi-NRTI exposed CLHIV who have been switched to lopinavir, ritonavir plus DTG as second line ART?
So again, yeah, the child is already on DTG based regimen, so no change has to be made here.
Have there been any additions?
And the monitoring has to be done as per guidelines.
Any added flavors for pediatric DTG?
It is strawberry flavored. That's what we know.
Do we have to repeat viral load yearly or 6 monthly for pediatric age group patients which are on first line ART drugs?
So after initiation, it has to be done at 6 months, then at 12 months, and then thereafter annually. And the children who would be transitioned to DTG based regimen, for them again a viral load has to be done at 6 months, 12 months, and then if they are on first line, then annually.
If a patient on ALE as first line ART and viral failure in spite of enhanced step-up adherence, what will be the regimen?
So if AL is the first line regimen, in such cases, ZLD should be given.
ZLD would be the answer.
How about monitoring of sugar levels? Will it be same as adult monitoring?
Yeah, and as I said, like there is no data currently to support that the blood sugar levels rise in children, but it is always good to monitor. So please, a 6 monthly monitoring for blood sugar is recommended.
Oh, now there was one question. In the slide, it was reflected that 5 dispersible 10 mg DTG is just equivalent to 30 mg of adult DTG as against 50 mg.
This is other way around. I think that is.
I've written the
yeah,
answer.
ma'am has answered it.
Yeah.
Answered it.
Okay, so
I'm
one
just
adult
putting it
tablet
for
is equal.
record.
One adult tablet is equivalent to 3 dispersible tablets.
I've answered it in the chat box.
Thanks, Dr. Rohini.
Yeah, I'll just take the questions from the chat box, remaining questions. Ma'am, can I stop sharing my screen now?
Yeah, sure. Yes.
Kiran sir, can you give mic access to everyone now? Yeah, thank you.
Excuse me, madam.
Yes, sir.
Good afternoon.
Yes,
I am Senior Medical Officer Dr. B.N. Tripathi from Bhubaneswar Riot Center. Ma'am, actually, these programs, CME programs, are not coming in our ART Center email. Kindly send the program in advance in our emails so that everybody can know and who can attend that in time.
Sir, can you please type your email ID in the chat box, sir? This has been noted. Please type your email ID in the chat box.
Okay, madam.
Thank you, sir.
Good afternoon, ma'am. Ma'am, I'm SMO of the ART Center, Dehradun, Dr. Handa. I had asked about ALDTG, LPVR and ZLDTG, LPR. Actually, our center is struggling with LPVR shortage since a very long time. We are not getting it. So what do we do for such cases?
Dr. Purnima, do you want to take up that? I think some stocks of LPVR are arriving, no?
No, what Dr. Eshu, what she's saying is that the patient is not taking LPVR for so many months.
No, I think that there are issues with the stocks. That's what I hear. It's not available.
So they are not taking, the children are only on 2 drugs. They are not taking the 3rd drug as LPVR. That's what she's meant. I hope that is what you asked, right?
Yes, ma'am.
That means
Okay,
these children are 2 drugs.
So they need to be put on with the existing NRTI backbone and DTG based ART and pediatric DTG.
No, ma'am, I'm asking like for those on special regimens from the PSASF, recommended from the PSASF. Like we have one child on ZLDTG and LPVR. We don't have LPVR. Now, what do we do in such cases? We have been sending demands.
So I
So,
think for
Doctor-
such specific cases, Purnima, you want to address that? Okay.
No, ma'am. I was just saying
No.
that
So I
because
was
they're
just saying
already
to
on
just keep
DTG based-
monitoring, keep monitoring these kids, and Dr. Purnima can add here with because NACO is still procuring some stocks of lopinavir for some specific cases. So that would be there, and such cases should be referred for CESER for their expert. I mean PCOEs for their expert opinion that what needs to be done in such cases. Please,
Thank
Dr.
you, ma'am.
Purnima.
No, you have already covered all the points. So LPVR will be available for special cases. And the regimen which I think Dr. Handa mentioned in her chat box was those patients are already on DTG base. So that was already addressed by you and Dr. Rohini. So, yeah.
Any more questions from the participants?
Yes, ma'am. Good afternoon, ma'am. This is Dr. Harshita, Sir, Medical Officer, ART Center, Kalavati and PCOE. I wanted to ask one question. In the slide previously mentioned, it's mentioned that DTG 50 mg is equals to 3 tablets of DTG 10 mg. So 50 mg, like there is for more than 15, for 14 to 20 band kg, there are 2.5 tablets for DTG 10 mg. So can we give 50 mg half tablet instead of that?
No,
I have a query.
no, you
No,
cannot
so-
give tablet, Harshita, because
Okay.
we are going to be giving dispersible tablets for all those who are less than 20 kgs. The
Okay, ma'am.
50 milligram DTG tablets are film coated and cannot be dispersed in water. They have to be swallowed.
Yes, ma'am.
Okay, so and that is to be given beyond 20 kgs. So do not do things like making 50 milligram half tablets. That's a
Okay,
wrong
ma'am.
principle itself.
Okay.
Yeah.
Okay, ma'am.
And
The way
secondly,
around-
it's a film coated.
Because there are lots
50
of
milligram
doubts
is a
in the DTG transition, ma'am. That's why.
yeah. So the DTG 50 milligram tablet is a film coated tablet and it is not
Yes,
to be
ma'am.
halved. It is not a
Yes,
sport
ma'am.
tablet. So that is
Yes,
not
ma'am.
to be done. And
Yes,
for the
ma'am.
children who are less than 20 kg, dispersible tablet DTG 10 milligram is recommended and should be used. The only
Mhm.
condition where the children are more than 20 kg but are
Yes, ma'am.
still not able to swallow.
Swallow. Okay,
In
ma'am.
those cases, in case no dispersible tablet needs to be given, then instead of
Yeah.
50 milligram adult tablet, what you can do is
Okay,
you
ma'am.
can do 3 tablets of pediatric DTG.
Pediatric.
That's the only condition. So I mean, other way around, it should not be done.
Okay,
So instead
okay,
of
ma'am.
pediatric DTG, adult DTG or the DTG 50 milligram tablet is not to be used. But in
Okay.
children where DTG 50 milligram tablet cannot be swallowed, in
Yes,
such
ma'am.
cases, dispersible tablet can be used, and for 50 instead of 50 milligram tablet, you need to give 3 tablets of DTG 10
Okay,
milligram.
ma'am. Okay, ma'am. Thank you so much, ma'am. Thank you so much for clearing my doubt.
Now I am Dr. Rakesh Lad, SMO, ART Center, Burhanpur. What should be done for the patient who are on abacavir, lamivudine, efavirenz, and zidovudine, lamivudine, efavirenz?
So ideally, sir, you should not have any patients on efavirenz right now. I think that
No,
NACO
we
is
are
not
having some
providing a
patient.
pediatric. But if you still have patients, they need to be transitioned to DTG based regimen directly. What you need to do is you do a viral load test for all these children. And if they are virally suppressed, in those cases with the existing NRTI backbone, you should use DTG 10 milligram tablet, weight appropriate dosage. And if they are unsuppressed, then you can shift them to ZL DTG.
Good afternoon,
Does that
madam. Good afternoon.
Good afternoon.
Madam, if a child is on AL plus DTG 50 mg and the weight increases to more than 30 kgs, do we have to change the regimen to TL or continue on ALD only?
So if the weight and age both increases, if the age is more than 10 years and the weight is more than 30 kgs, in such cases, you do a viral load test. If the child is suppressed, you can shift the child to TLD. If the child is not suppressed, then a CESER referral has to be done.
Okay. And another scenario wherein the child was initiated on TLD because the age was more than 10 years and the weight was more than 30 kgs. And subsequently, if the weight goes below 30 kgs, do we have to change it over to AL?
So, madam, in such cases, you have to actually review the child for weight loss. What is the reason for weight loss?
Yes, sir.
Yeah, and it is advisable to take opinion from your CLHIV or the PCOE in such cases, because I mean, unless there is an OI, weight should not be decreasing. So please, look into the issues or the reasons for weight loss, and then take appropriate guidance from your PCOE.
Thank you. Thank you.
Excuse me. Hello, good
Yes,
afternoon.
ma'am.
Yes, suppose the blood sugar goes on increasing, what should we do? Some patients do not agree to take DTG. We know that metformin cannot be given more than 1000 mg. Hello.
So for today, for today's session, we are discussing mainly the pediatric DTG, and with pediatric DTG, as of now, we don't have a documented evidence for hyperglycemia or increased blood sugars. Okay. So I don't foresee that scenario that it would happen. And let's see how our patients, how our kids respond to DTG, and then we can discuss these kind of issues. And for the adult piece, I think we'll discuss that in some other forum.
Okay, thank you.
Ma'am, I'm not sure if this question has been taken. What about co-infection CLHIV? Do we need to give a booster dose?
Booster dose or boosted PI?
It's a booster dose has been taken.
So I'm just co-infection with the TB. That's the question.
Yes, ma'am. Yes, ma'am.
Okay.
Yes, ma'am.
So twice daily dosage for age appropriate DTG 10 milligram has to be used. So if a child is on 0.5 milligram dose of DTG, sorry, half a tablet of DTG, then it has to be given half in morning and half in evening. So the dosage has to be doubled 12 hours apart.
Okay.
And you need not use any boosted PI or anything. So we are just here. I mean, it actually simplifies, and especially for the children who are co-infected with HIV.
Ma'am, it's not audible, ma'am.
Reshu, ma'am, you're not audible.
I'm not audible.
Yeah, you're audible.
Am I audible now?
Yes, yes, ma'am.
No. So what I said was, when we are using DTG based regimen for children who are co-infected with TB, the only thing we need to do is to double the dosage of DTG. So whatever age appropriate dose is recommended for the child, a BD dose has to be given 12 hours apart.
Okay.
And no super boosting with a PI is required now. So this is the most simplest regimen which is now available for co-infected children, because managing co-infected children was always an issue, and super boosting the drugs were not available. So now the DTG, the extra dose can be given from your ART center itself. So it shouldn't be very difficult to manage these cases now.
Okay, ma'am. Thank you.
There's one question. When child is shifted from AL to TL, Rohini ma'am has already answered that. Sorry, ma'am. Any more questions from the participants? Please feel free to unmute, or you can type your questions in the chat box.
Excuse me, ma'am. I am
Yes,
a medical officer from ART Indore. Ma'am, I wanted to just ask one question. Like, we have started one child on ART, and it's only 1 month since we have started. Like, he has taken only for 1 month. We have initiated with ART with this patient. So how can we transit this patient? We cannot get his viral load also done before 6 months. So how will we transit this patient to DTG? Because this is a new initiation. So it's only 1 month since when.
Yeah. So this was very well explained by Dr. Rohini.
This child is also on ATT, ma'am.
So no problem. What you need to do is with the existing NRTI backbone. So if the child is on AL, is the child is on AL?
Yes, ma'am. AL with LPVR.
Yeah, so now you can shift this child to AL plus DTG. And for DTG, twice daily dosing has to be given.
Yeah, that's okay. But
If the child is on
viral load,
DTG.
when are we supposed to do viral load of this child?
After 6 months, after 6 months of transitioning to DTG based ART.
Okay, okay, ma'am. Thank you, ma'am.
So all the children who have not completed 6 months on ART, for them, they should be shifted to DTG based ART along with the existing NRTI backbone. So ALD, in most cases, this would be ALD. And then a viral load has to be done after 6 months.
Thank you.
Any more questions? Ma'am, I don't think there. Okay, there's one we have initiated. We have initiated on AL plus lopinavir yesterday. We will have to transition for this child also.
I've answered.
Yeah, you have answered.
Good evening, ma'am. This is Dr. Shilpa from MP. Ma'am, I want to ask one question. If the child is initiated on ALE 2 months before, can we shift this child to ALD without doing viral load?
Yes, any child less than ART duration less than 6 months, viral load is not required. You can directly shift the child. You don't need to do viral load if the ART has been started less than 6 months of duration. Okay.
Okay. Thank you, ma'am.
But document it and document the date of transition, because your next viral load is going to be from the date of transition to DTG based regimen and not from the date of starting ART. Okay. So,
thank you, ma'am.
Any more questions? Ma'am, I don't think there are any more questions.
Yeah, if there are any questions, I think participants can send them to NAPO.
Yes, ma'am.
And we can perhaps close this session.
Yes, thank you so much, Chinmay ma'am and Dr. Purnima ma'am for joining us today. Thank you, Reshu ma'am, and thank you, Rohini ma'am, for facilitating this session. Thank you to all the participants for patient listening. Can we conclude the session now, ma'am?
Yeah, please.
Thank you.
I think Dr. Chinmay is there.
Yeah.
Dr. Chinmay, you can just ask Dr. Chinmay if she has some closing
Dr.
remarks.
Chinmay ma'am.
Yeah. So thank you, everyone. Thank you, Dr. Rohini, Dr. Reshu, and Purnima for this exhaustive session that you took, and I hope it was useful. Any further questions, if any SACS, ART Center or PCOE has, please write to us and we'll get back to you. And please don't miss the next session, which is going to be very important. Thank you. Thank you, Shweta.
Thank you, ma'am. Thank you.
Thank you.
thank you, ma'am. Good day.
Thank you to all the participants. We'll conclude the session now.
Thank you, everyone.
Thank you, everyone.